Good evening. It's Tammy Northam here. We're just about to get started, and we're right at 7 o'clock. So let's get going this evening. Welcome, everyone. We're so pleased that you've joined us this evening. I'm Tammy Northam, Bladder Cancer Canada's Executive Director, and I'm your MC for this session on how new immune and targeted therapies are changing bladder cancer treatment. We hope that you'll come away from tonight's webinar with a better understanding of your diagnosis, treatment, and future outlook, and some tips to help you along the way. But before we get started, we have a few housekeeping items to go over. First, to ensure the best possible audio experience for everyone, we have you all on mute in order to minimize the amount of background noise. While you'll be able to hear us speaking, we're not going to be able to hear you. So if you have a comment or a question during the session, the best way to submit your question on a computer is to type it into the question box at the bottom of your GoToWebinar panel. If you're on a mobile device, like a tablet or a cell phone, click on the question mark icon. Please keep in mind that we will not be able to address questions that are specific to your case, but we will do our best to answer as many general questions as we can during the Q&A session following the presentation. Please keep your questions short and succinct. If you find that you're experiencing technical issues, please send us a note in the question box and stick with us as we work to resolve the problem. Lastly, we are recording this session, so if you get called away or disconnected, keep in mind that you will receive the recording in the coming days. To help us understand the composition of our audience tonight, we would ask everyone to respond to the poll that will appear on your screen any moment now. So we'll give everyone about 15 to 20 seconds to answer, and then we'll continue along. Okay. So you should be seeing that poll on your screen right now. So we'll just give you all a couple of minutes to select your response. All right, I am going to close off that poll. And here's your results. So almost 80% of you are a bladder cancer patient, 8% a partner of a patient or survivor, 3% a caregiver, 5% healthcare professionals, and 11% other. So thank you for your responses, everyone. All right, so I'm just going to move along and give you a bit of a brief introduction to Bladder Cancer Canada. So just to give you a bit of an overview, Bladder Cancer Canada is the, just looking at my screen, there we go, first and only national and patient-focused bladder cancer organization. It was co-founded by two patients in 2009, Jack Moon and David Gutman. Our mission is threefold, and that is to support patients, increase awareness and education, and fund research into bladder cancer. We are made up of a national board of directors of 10 volunteers, 1 full-time and 4 part-time staff. We have over 400 volunteers that we work with on a daily basis, and we have over 7,000 individuals registered with us to receive information. And we are honored to have 26 of the top bladder cancer specialists in the country as part of our medical advisory and medical research boards. And they really, they help us out a lot with advising us on our research and our programming. They review our patient support materials. They support our activities from all across the country. They promote Bladder Cancer Canada in their patient community, and they assist us with the development of standards of care. And these people are all volunteers giving of their time freely. So this is our website here. So if you haven't had a chance to check it out, we encourage you to have a look around. There's a lot of great resources to be found here. So talk a little bit about the first part of our mission, which is patient support. So the one-to-one patient support program. So we receive approximately 100 phone calls or emails a year that we respond to, and so volunteers will intake that call and disperse it out to a trained volunteer who can speak with that person individually and help offer support and a listening ear. We also have an active online discussion forum, so we encourage you to check that out. And you can participate, certainly, but you can also just read. You can search by topic and find lots of useful information there. And these are some of the individuals that are so generous in volunteering their time to help us out with these programs. We also host education meetings across Canada. So this year we will be organizing 6 meetings in various cities, and we will be sending information out through our newsletter about those upcoming meetings. We also have a number of support groups that are run by volunteers across Canada. So if you would like to learn more about where some of these support groups exist, you can go to our website and have a look. And we have our educational guidebooks. So there's 4 guidebooks in total. We're excited to be launching a brand new guidebook on metastatic bladder cancer this spring. It's available online to you to download for free, and your urologist or your doctor can order as many copies as they want for no charge to them to provide to their patients. We also have a number of informative videos on our website for patients featuring members of our medical boards and leading researchers. And just a note that these webinars, like this one tonight, will be posted to our website for a long period of time following the webinar. So I've talked about patient education and support. Let's talk a little bit about our awareness program. Many of you will be familiar with the See Red, See Your Doctor program. And just of note is that most of the artwork in the advertising space is donated. So this program, public service announcement, costs Bladder Cancer Canada very little. And you may have seen it across the country in transit shelters and on digital screens, also airing on national television as a public service announcement. So the next slide will show you the reveal of our refreshed awareness program. And so here it is, a twist on the lemon. We are launching it across the country this spring, and we expect the video asset to be coming in May 2019. So we're really excited about that. A little bit more daring and a nice change from the last campaign. And then we also create awareness with patients. So we have brochures in doctors' offices across the country, and we have volunteers who assist us with distributing these brochures out in various centers. And we also have our See Red brochure in 1,700 GP offices in donated card racks across Canada. So we're very fortunate to have that donated space. And just of note is that we're always needing new volunteers in this area. May is Bladder Cancer Awareness Month. This year, a very special year. It's the 10th anniversary of Bladder Cancer Canada. So we will be celebrating the entire year. Our birthday is May 11th, 2019, 10 years old. So stay tuned, watch for information. And the third part of our mission, we do fund research. As most of you know, bladder cancer is the 5th most common cancer in Canada, yet ranks very poorly compared to the top 24 cancers in terms of research funding. So we, as an organization, are working on changing this, and through the generous support of our donors and our fundraisers and sponsors across the country. As of now, we have funded over $1.5 million cumulatively in research, so we're very proud of that. The final part of our work that we do, I should talk a little bit about, is our advocacy work. So these are some of the things that we work on as an organization to ensure that the voice of Canadian bladder cancer patients is heard. And finally, just a little bit about our biggest fundraiser and awareness event of the year, which is the Bladder Cancer Canada Awareness Walk. Certainly, it raises 65% of our revenue for the year, but more importantly, bringing several thousand people across the country together to learn and connect and make a difference. So our date for next year is September 22nd. It may vary slightly in some cities, but after May 1st, you can visit bccwalk.ca to register or learn more. And I wanted to just take a moment to thank our sponsors who made tonight's webinar possible at no cost to the people here. All right. So I'm just going to, that's the end of my presentation, so I'm just going to take a couple of moments now to introduce Dr. Ong. He's our presenter for this evening. He is a medical oncologist at the Ottawa Hospital who specializes in advanced treatment of urologic and skin cancers. He trained as an oncologist in Canada and as a researcher in cancer drug development at the Royal Marsden Hospital in London, UK. Dr. Ong is a leader in clinical trials of new cancer drugs in Ottawa, and he has a high-level expertise in cancer immunotherapy. Nationally, he is a recognized lecturer in urological and skin cancer treatment, an executive on the Investigational New Drug Committee of the Canadian Cancer Trials Group, and the current chair of a trial testing non-invasive ways of personalizing prostate cancer care. So I'm going to just take a couple of moments with my technology and ask Dr. Ong to join us on his webcam. And then I will.
Hi, everyone. Welcome.
Turn the presentation over. Let's see.
Got it there, Terry.
Okay.
Okay. Okay, I think we're rolling, right, Tammy?
It looks good, but if you at any time have any questions or you need me to come online, I'll be here on mute.
Perfect.
Thank you.
Good evening, everyone. Welcome to the webinar for tonight. Tonight I'm going to be talking about how immune and targeted therapies are changing bladder cancer treatment. It's a cold day in Ottawa, and because it's springtime, but we had a massive snowfall here, so I hope the weather wherever you are is better than here. So I'm going to advance here. Perfect. So this is the outline of what we're going to talk about today. First, I'm going to talk about when does someone like myself, a medical oncologist, get involved in the care of bladder cancer patients. So why do we use drug treatments in this disease? And then what are new drug treatments that are on the horizon or already being used? What types are there? What is approved now? And what are some of the risks and benefits? I'm going to touch on clinical trials because I think at the moment for bladder cancer management, a lot of these new agents are still being tested in clinical trials. So it's important to know what are trials, how do you participate? And finally, there's a segment on what you can do as a patient to navigate this complex area. So there's a fantastic webinar already that Nick Power had put on, and I'd encourage you to look at it if you haven't already. It really complements the material today, and as you know, the journey for somebody with bladder cancer does often start with blood in the urine or some other symptoms that leads to a connection with a urologist, a specialist. And often I think where that urologist accesses more specialists depends on how risky the situation seems to be in the bladder. So here's just a picture of a cystoscope looking at a bladder tumor, and what's not easily apparent right here, just looking at this picture, is how deep does this bladder cancer go. So when does a urologist refer to a specialist like myself or a radiation oncologist? Well, generally if there is what there is considered to be high risk cancer, and the part that would be high risk is if the cancer or the typical type of bladder cancer called urothelial cancer grows into the muscle of the bladder. And the other situation is if there's a spread of that cancer outside of the bladder into lymph nodes near the bladder or even farther along, or sometimes it involves other organ sites that are far beyond the bladder. So how do we know if the cancer is muscle invasive? Well, this is the procedure that Dr. Power had been talking about, where through a scope and a camera, they can actually shave the bladder cancer and get a bit of the muscle that is in the bladder. This is called a transurethral resection of a bladder tumor. And it's important for removal of the bladder tumor, but also to know how deep the bladder tumor goes. So if it does involve the muscle, we consider these to be high risk. So these samples are then sent to the pathologist that does extra stains and looks at under the microscope. And as you can see on this particular slide, it's difficult to interpret just if you have no training in it, but there's bands of muscle here, and you can see those darker spots, darker purple spots here are cancer cells within the muscle. So a lot of the times we talk about staging of cancer. So this is just a diagram of the layers of the muscle. So the closest to where the inside of the bladder is in the urothelium, the closest to the inside of the bladder is called the urothelium, and that's where that term urothelial cancer comes from. And then there's the next layer, the lamina propria. And so when you have non-muscle invasive bladder cancers, that you may have multiple surgeries to resect those by your urologist, that's a T1 lesion. But if it goes further into the muscle, that is generally staged as a T2 lesion or a T3 lesion if it goes further beyond the layer of the muscle into the fat. So it's important to know that you can't tell how far something digs just by the cystoscopy or by the transurethral resection of the bladder tumor procedure alone, because the urologists, if they do this procedure, they can't go beyond the muscle. If they go beyond the muscle, you could create a hole in the bladder. Obviously, that would not be ideal. So they can scrape up to the muscle, and how far the tumor goes beyond, we tried to look at imaging, or perhaps through the procedure, the urologist had a good idea if there was more involvement. So here's an example of a typical scan that we would do to further stage somebody that we thought had muscle invasive bladder cancer. So on the left side, there is a normal CT scan. The bladder is just that almost rectangular structure in the middle between the pelvic bones, and there's no tumor on that left side. But on the right side, you can see that on this contrast scan, there is this irregular structure that's a little bit more whitish inside the bladder, and that's clearly abnormal. On these types of scans, we look not only at the bladder structure, how thick the bladder wall is, which is typically a very, very thin kind of membrane, and we also look for lymph nodes. So we look for the lymph nodes around the bladder or potentially beyond. So in this particular scan, unfortunately, on the right side of that bladder, that there's some thickening. There's an obvious thickening where that star is. So there's a mass that's seen, and then in the arrow sign, there's a little bit of a small lymph node that looks suspicious as well. Okay. So we try to take all that information into account when we're making decisions with patients as what to do with a high-risk muscle invasive bladder cancer. And we know that we can't, well, if you take out the bladder right there and then in that situation of muscle invasion, there is actually a mixture of how far the cancer has actually gone through the bladder or through other lymph nodes nearby. So half of patients with muscle-invasive bladder cancer only invaded the muscle and not through the muscle wall and not to lymph nodes. And if that's the case, it's only in the muscle alone, then the prognosis is better on the spectrum of muscle-invasive disease, 80% of patients surviving without having any recurrence. But a quarter are actually through the muscle of the bladder, and it can just be a small amount, meaning microscopic, or it could have been seen on CT scans ahead of time. And in those cases, only 50% of patients survive without having recurrence. And then if typically when the bladder is removed, the lymph nodes in the surrounding region are removed by surgery as well. And in a quarter of cases, the cancer has also spread to those lymph nodes nearby. And if that's the case, 30% of patients will survive long-term without having recurrence. So one of the big problems in this type of cancer is muscle-invasive bladder cancer. We can't reliably tell preoperatively how deep the cancer went and whether the lymph nodes are actually involved. And if you just take this group as a whole, half of people are at risk of the cancer coming back. So that's why a medical oncologist like myself would get involved in these cases, because it's our job to offer drug treatments that could potentially reduce this risk. And so we know that whether the bladder is treated in this situation with surgical removal or radiation, that's really treating the local bladder cancer, but by virtue of the fact that it's actually gone into the muscle, there's a chance that some of the cancer cells have already slipped into the bloodstream before the bladder even got treatment. So no matter how much treatment we direct at the bladder, whether it's surgery or radiation or chemoradiation, it's still not addressing the problem that some of these cancer cells have jumped into the bloodstream and can circulate around, and at a later time can actually grow. So this is why drug treatments are incorporated, because we can actually attack the cancer wherever it is. So it's a team approach for bladder cancer treatment, and it can be quite complicated, the type of situation. So in Ottawa, for example, we have a team of 12 oncologists. I mean, whether they're surgeons or radiation oncologists or medical surgical oncologists, and we discuss many of the more complicated cases as to what is the right decision for the situation. When is it best to incorporate chemotherapy before or after surgery, or before and after chemoradiation even? When is it best to do surgery, or when are patients allowed to take an alternative approach called bladder sparing approaches, where we, another term for it's called trimodality therapy, where we try to scrape out the bladder cancer through the scope, then apply chemotherapy and or chemoradiation to the bladder, and then monitor to try and not do a surgery to the bladder. But this approach mainly works in very carefully selected people, because there's if you're not selecting patients properly, there's a chance it won't work, and patients will get surgery anyways. So this is a complicated decision at times, and it's important that communication is very open between the different specialists, because the answer is not always very clear as to what the best approach is for each patient. So what's exciting, and the topic that I'd like to delve into more today, is what's new in drug treatment. So we know that radiation, surgery, and chemotherapy are the pillars of treatment for bladder cancer, but nowadays a lot of headlines, a lot of trials, a lot of excitement around immunotherapy and also some new targeted therapies for bladder cancer. So these therapies have come because we've been doing a lot of science, a lot of work trying to know why do cancers develop, what happens when they develop, how can we find the Achilles heel to actually target these cancers in better ways than just using chemotherapy. Immune therapy is a very attractive concept because intuitively your immune system knows the difference between self and non-self, and therefore can be potentially very directed towards something that it thinks is foreign, sparing any kind of side effects for what it thinks is self. So there's a few key things about the immunotherapies that are different than some of the treatments we traditionally use. One is this idea that it's very specific to its target, its antigen that it's trying to attack. Another is that it's adaptable. So we know cancer can evolve and change with time. And so that idea that the immune system can adapt with it is very attractive. And the third thing is that the immune system has memory. So sometimes even after we stop an immune therapy, the effect can be ongoing and we no longer need to treat people. So these are very attractive properties of immune therapy. It's also an important part about immune therapy, though, is that you need to have something that actually looks quite different than the body for the immune system to attack it. Bladder cancer, this is a graph showing how many mutations different cancer types have compared to the body, and is expressed in mutations per megabase. You can see that if you're closer to the right, like bladder cancer is, you tend to have more mutations, generally speaking. And that little green line separates, I guess, who it tends to have a lot of mutations. And you see that no matter what cancer type you have, at least in adult cancers, there are some people that are above that line and have a lot of mutations. But bladder cancer generally, perhaps because there's an association with smoking, but there are also some inherited reasons why some people get bladder cancer, there can be a lot of mutations present. So if more mutations, more changes in a cancer compared to the body, the more chance that it can look foreign to the immune system. So if this is the case, I guess, why isn't it that your immune system automatically gets rid of the bladder cancer and you don't need any kind of further treatment? Well, it turns out that long time we're doing a lot of trials in the past about immune therapy because I know trials dating back until the 1980s, really looking at drugs like interleukin or interferon, and they never worked, and it's because we were missing a critical piece of the puzzle. So I'll just explain that to you, that this slide shows two scientists that just won the Nobel Prize in 2018 for this discovery of immune checkpoint inhibitors. So Dr. James Allison and Dr. Takusu Honjo separately had discovered aspects of the immune system that were checkpoints. So here's the scientific slide as part of the Nobel Prize winner presentation, and here I also treat melanoma, so a lot of these concepts were first tested in melanoma. So there's an idea that you basically have a piece of the cancer that is foreign to the body, and what they call a tumor-associated antigen, a TAA. And this antigen is eaten up by the immune system and then presented to what we would consider to be the army that attacks cancer cells, the cytotoxic T cells. or CD8 positive T cells. And so these antigens that are foreign are presented, and then there's a signaling that occurs that activates that T cell and tells it, well, replicate your cells and go out and search for this antigen. So there's a T cell priming phase that you need to train T cells to find this antigen, and then once these T cells are created and they migrate out and looking for the cancer, once they get near the cancer, they can also try to attack the tumor. So these checkpoints are called CTLA4 and PD1. And CTLA4 is what stops you from priming these T cells in the first place. And the PD1 is what prevents the trained T cells from attacking the cancer. So I'll try to simplify this because I know at first pass that you might not get all that. So bottom line is, and I'm reading Harry Potter to my kids, so maybe this is on my mind, but there's essentially an invisibility cloak called PDL1 that cancer can hide itself from the immune system. It's this cloak. And anytime a T cell with a PD1 receptor bumps against this cloak, it actually decides that it's not going to do anything. It's going to just go searching elsewhere, or actually it's the PD actually stands for programmed death. So sometimes it actually completely silences these T cells. So what's amazing now is that we have these custom antibodies that can block the PDL1 or the PD1. And once you do that, you actually block this cloak signal, and suddenly these T cells can see this cancer, it can attack this cancer, and it really, when it works, it can work unbelievably and right away. Now, it's complicated whether this T cell is aware of this cancer and whether it can do its job even after this cloak is removed, which is why not everybody benefits from this approach. So another way to think about this, this is my own analogy, is PD1 and PDL1 and CTLA4, if you know how to drive stick, it's like pressing on the clutch. You're basically disengaging the engine of the car. So it really doesn't matter how hard you press on the gas with other inflammatory things like interleukins or interferons or vaccines or viruses or any of these things. It doesn't matter how hard you press because your engine's disengaged. So we really, this immune checkpoint blockade is a very critical piece in trying to engage the immune system. There are other things that we can potentially do to augment that, and I think those are going to be the part of clinical trials in the future. Also, there is a brake in the car, and sometimes with these immunotherapies, we've gone too far, and there's the possibility that we can actually calm the immune system down with things like steroids or immune suppressants. So here's an example of one of my patients. You give these immunotherapies to, and this is a PET CT scan, and on the left side is the baseline, right is 4 months later. And treatment of these immunotherapies, person's own immune system is getting rid of these spots of cancer in the lungs in this case. And it can do it with no side effects, but of course there are potential side effects. It has to do with one's own immune system attacking the body. But the fact that we can do this is I think, quite remarkable. And so we were in Ottawa, and there's Kailash Sridhar too here, part of the original durvalumab study that led to approval of this immune checkpoint inhibitor in bladder cancer. And there are many others, such as pembrolizumab, atezolizumab, nivolumab, avelumab. The target of these is very similar. I mean, there's some differences to an oncologist, and there's a reason why pembrolizumab, for example, here is a preferred option in this setting, as immunotherapy because of very specific trial data. But overall, I mean, the intent of these treatments is similar, and your medical oncologist, if you need one of these treatments, would be the one to decide in your setting what's the best treatment. So as you can see, these medications are approved and used currently for metastatic cancer. So in Ottawa, here's a graph of immunotherapy use, and you can see that it's very recent where we had an increase in uptake of these new immunotherapies across many different cancer types because of different trial data. And it's not just used in clinical trials. The red bars are standard treatment. So not only have these exciting trials led to very interesting results, but actually changes in practice that are very recent. And of course, there are potential side effects. Generally speaking, if you're using an anti-PD-1 or an anti-PD-L1 drug, generally well tolerated. However, I would emphasize that there can be very significant side effects from these drugs in selected patients. I think it has to do with the fact that some people, and everyone is different, their immune systems are primed to attack themselves. And we didn't know it. I mean, we know that there are autoimmune diseases that can occur, but some people don't have overt autoimmune symptoms. And yet when we give some of these drugs, there can be severe side effects. So that happens in about 5% of people, where it could be inflammation of something as critical as the heart, for example, or the brain, or nerves. And we've had some patients that develop diabetes as a result of these drugs that is insulin dependent. So these are significant side effects that we can't predict for at the moment. There's a lot more that we need to learn. About 20% of people may not have these really severe side effects, but may still need to stop. And we need to give an anti-inflammatory like steroids to manage the side effects. So certainly overall the rates and tolerance are better than chemotherapy alone, but we're still learning how to use these, how to manage these side effects. So where are we in terms of the use of these agents? Well, as I've said, after there are clinical trials that are testing these immunotherapies for almost every situation around high risk bladder cancer. So before surgery, together with chemoradiation, after surgery, and even, well, we've already accrued to a lot of these clinical trials that tested as first treatment at recurrence for metastatic cancer, and we're eagerly awaiting some of those results, and is already approved for second line treatment. It's important to remember that I'm not saying that immunotherapy is necessarily an alternative to chemotherapy, because chemotherapy itself can have important effects. And for example, this is a trial of upper tract urothelial cancer, so not bladder cancer, but cancer of the tube to the bladder. And it reduced the chance of recurrence by 51% in this recently reported trial. So, so chemotherapy may be the right choice for patients. We're doing trials now testing combining chemotherapy and the immune therapies as well. So I think there's a lot more to come. So just touching on clinical trials, only about 5% of patients traditionally participate in clinical trials at centers. But really, it is the only way to advance cancer treatment for the next generation. And it can actually benefit patients themselves because of access to the newest, most exciting treatments. And there is very close monitoring and study that occurs because there's a research associate that can be a great resource for the patient, and things are very closely monitored. Of course, clinical trials do require a high time commitment, though. There can be extra testing and sometimes even tests like biopsies or extra scans. And that can be time consuming, and not everyone wants to be involved in that. And new treatments can also have unexpected side effects, so it's important to be informed about what kind of trial we're talking about and what the potential benefits or risks are. And of course, having a trial does not assure that the new treatment works. So that's the point of these trials, is to see whether we are able to change practice. Fortunately, in the recent past, trials have led to very big changes in the way we treat cancer and what's to come, I think. So I'll just highlight a few of the things that are making some headlines in bladder cancer. For example, here's the technology called antibody-drug conjugates. There's this drug called enfortumab vedotin, and it essentially is targeting, it's an antibody that targets this Nectin-4, and it's linked to chemotherapy. So when it finds the cancer internalizes this antibody, and actually it delivers a chemotherapy within the cancer cell. And so some of these results have been very interesting. There's another drug called fibroblast growth factor inhibitor, and drugs like regorafenib or erdafitinib are examples of drugs that block this growth signal that's on in about 30 to 40% of bladder cancer. These are drugs that we're also testing. So just the last few slides are my advice for patients. When you go to your appointments, I think bringing an extra set of ears and writing things down is very important. I think it's very important your voice is heard and what's important to you in terms of your treatment. It can be a very complicated decision for treatment of high-risk muscle-invasive bladder cancer. So your team needs to discuss your case and come up with their best suggestion for you. And that can be a discussion between your surgeon, radiation oncologist, medical oncologist, but also involving radiologists and pathologists. Ask for handouts in case this could help you with your decisions and alternatives, and also consider clinical trials. So in summary, bladder cancer treatment is changing, and chemotherapy remains an important part of treatment, but immunotherapies have already been adopted for recurrent metastatic disease, and I think they're going to be tested and improved in really every aspect of high-risk muscle-invasive bladder cancer as well. So I encourage you, if possible, to consider participating in clinical trials and certainly communicate with your whole team about the best options for your situation. So thanks so much for having me for this webinar, and I look forward to some questions.
All right, thank you, Dr. Ong. What an excellent presentation. I really enjoyed that and certainly learned a lot myself this evening. We are going to, folks, move into our Q&A session now. I understand quite a few questions have been coming in, and we've got lots of extra time here this evening for your questions. So Dr. Ong, you can just leave your camera back on for the time being if you'd like, and to take some of those questions. I'm going to invite Carrie Abbott, BCC's program manager, to come on the line with us, and she's going to be addressing some questions with you.
Hi, everyone. Thank you for all of your attendance tonight. We've got quite a few of you on the line, over 60 folks, so that's pretty great. And lots of questions, as Tammy mentioned, and we'll start with one of the more concise ones, and that is, you used the term high risk several times, Dr. Ong. Is high risk bladder cancer the same as high grade?
So generally speaking, when I'm seeing somebody, they will have high-grade carcinoma. And the low-grade carcinomas tend to be and are generally non-muscle invasive. So it is, so it's not, I have not seen a muscle invasive low-grade urothelial carcinoma that we had to then put on treatment. So so I'm terming it high risk because I'm just trying to present it as something that is tangible for the audience today. But in the medical world, we just term it muscle invasive, and that's what we think of as high risk.
So the term, and I'm being devil's advocate here because I think I understand where this question's coming from. When we're looking at the tumor itself and it's being graded and staged and graded, high grade is a specific tumor type, correct?
High grade is when the pathologist looks at it under the microscope and they think that it is dividing very quickly and is being aggressive. So it's a specific term for that appearance. It does not have to do with how far down into the muscle, into the bladder wall that it goes.
Okay, I think that may be the answer we were looking for. Thank you. So another question is an interesting one, and that is immunotherapy use national or limited to certain centers, and would patients located anywhere in Canada have a path to these options?
Yeah, so drug approvals are somewhat complicated in Canada because we have Health Canada that will approve a drug for a particular indication, and it is equivalent, for example, to the FDA in the United States. However, it is up to province whether that drug is actually funded for use in that situation. Now, there are national organizations that try and facilitate some coherence between, province to province having similar approvals, but it is not identical. And of course, there are situations where things are approved in one province, not another. So it's, especially since all of these approvals are new, sometimes there's a time delay between the approval of a drug by Health Canada and the actual funding. That's where sometimes there are access programs for these drugs through pharmaceutical companies where they are giving it away for free because they have positive data. So the answer is it's complicated.
Yes, thank you. I figured that one wouldn't be a simple answer, but I appreciate your answer and explanation. I'm trying to look at what we've got here already and all the questions coming in. I guess we'll go with, does Enbrel, which is a common, I guess, rheumatoid arthritis drug, inhibit the immune response for bladder cancer treatments? Is there any evidence of that?
Yeah, so, there's a complex interaction of the immune system and cancer. And we know that in some cases, when we suppress the immune system, it allows cancers to come and grow. It is more complicated as to what the interaction is about drugs like anti-TNF drugs, for example, and whether that impairs immunity. And I don't truly think we have good data to know the answer to it, because the majority of clinical trials that enrolled people for immune checkpoint inhibitors excluded people that were on immunosuppressive medications. So only now that the drugs are approved, we are allowed to consider giving these drugs in these situations, and we don't know the answer. Often, I think in my experience, it's been the wrong decision to stop these medications if they're being used for an existing indication just to get immunotherapy. I think it'd be sometimes more advisable to consider using immunotherapy. It may not be as effective, but at least it won't be harmful.
Okay, next question. Future use of immunotherapy in non-muscle invasive bladder cancer. There's someone here saying that their husband is getting treated for non-muscle invasive bladder cancer. Would that be a trial, most likely?
Yeah, so I mean, there's excitement about its use in non-muscle invasive bladder cancer and preliminary data saying that it might be something that is used in the future. But the follow-up time on those trials have simply not been long enough for us to know if it's being effective enough in preventing muscle invasion in the future. I mean, we don't want to get to the point where we're even considering removing the bladder or chemoradiation. But it's early days. I think that that's why participation in trials is important in these situations, because we don't know what the potential benefits are. And as Dr. Power has noted, not all non-muscle invasive disease is the same. There's some low risk and there's some high risk. So who would we treat? I pointed out that these immunotherapies are not 100% benign. Okay, there are some serious side effects that can occur, so we certainly don't want to give it to anybody that is not at risk of their cancer worsening.
I think that segues somewhat into this next question, and that is, how do you get selected or involved with a clinical trial, and are they safe? So obviously there's some weighing of pros and cons there, so I'll let you answer that one if you can.
No problem. So part of the reason why clinical trials don't let everybody in is because Health Canada and the FDA have lots of safeguards on these trials. So they say, your lab work has to be perfect. You can't have these particular diseases because it would be unsafe if you're using these immunotherapies with these conditions. And they're very rigid about the timing of everything. For example, surgery and then treatment within 12 weeks or something like that. So that's why so many people in trials get excluded from participation, and it's frustrating for, say, both a clinician and the patient when they can't get a trial they think somebody is fit for, and it would be potentially beneficial. It also speaks to sometimes, if you have such a narrow population in a trial, is it really widely applicable once you get the results? So it's a balance between trials trying to be safe and not just getting anybody in a trial versus how widely it can be applied. So I hope that tries to answer the question.
Yeah, I definitely, you did a thorough job of answering the second part, and I'm just wondering, the first part, maybe you need BCC to get involved in some of these cases, is how does someone get involved with a clinical trial? So obviously
Right.
We can't advocate, but we can direct people towards resources. Do you have any suggestions in that way?
Yeah, absolutely. So I know that Bladder Cancer Canada themselves have some resources that can help link you to centers that potentially have clinical trials, and you can find a center that might have something that you're looking for. And also there are independent resources such as clinicaltrials.gov.gov that worldwide list various clinical trials that are open. And clinical trials, I mean, it's not going to be universally open. Like trials that we have in Ottawa may be very different than in Toronto, Vancouver, and other cities like London, Ontario, where I'm from. So everybody has a little bit of a different portfolio. Generally speaking, the very big trials, the registration trials that have hundreds of centers in the world, it's likely that multiple centers have them. But if you're looking for something that might be a smaller trial, it may only be open at one or two centers. So it's important to be informed these days with the web. It's easier to be informed, like at the session today.
Great. This next question is, I think, completely different, and I don't know if you can answer it, but do interferon bladder installations have any long-term effects? This person says they had a systemic reaction. So generally speaking, is that something that might be, that's obviously not necessarily a long-term effect, that might be more of a side effect, but in terms of long-term effects.
I don't have any personal experience with interferons in the bladder, but I have experience with using interferon as a subcutaneous and intravenous treatment. In those cases, we're trying to inflame the body. I mean, we're trying to give something that, when you have the flu, you have this high level of interferon. And sometimes the body reacts by training the immune system, and there can be long-lasting effects. It's possible, but it's hard to show. So in melanoma, for example, the people that did best with these interferon treatments actually had long-term side effects of some sort, such as development of vitiligo or these antibodies, anticardiolipin antibodies that were measurable in the blood. So that's the best answer that I can give you.
It's a good answer, given your limited experience, as you admit. This individual says, I'm not sure he'll discuss this, and I don't know if you'd have an answer, Dr. Ong, but are you following the Canadian company that's using light-activated photodynamic compounds and with associated drug formulations that are in clinical trials right now?
No, I have not, probably because I'm not a urologist.
Yeah.
So,
something they should ask their doctor about.
I mean, it seemed, in my mind, perhaps suited to be tested in non-muscle invasive disease, but I think muscle invasive disease, we're talking about, obviously a different area.
So a more general question here, switching directions. What would you say is the future of bladder cancer treatments if you had to sum it up?
Well, I think it's exciting that there are many different therapies that are being developed and tested and approved. So I think the closest thing is going to be how immune therapies are going to be integrated into treatment of high-risk bladder cancer, muscle-invasive bladder cancer, that to prevent recurrence at all. And whether we can utilize these types of therapies and integrate them in bladder preservation strategies as well, because it's a tough thing to have to get your bladder out. So if there are ways that we can prevent more people from having to lose their bladder, that would be, I think, hopefully in our future. Some of these new medications, harder to tell how they will be integrated into bladder cancer treatment, but if we can get more active agents, more drug treatments that are effective in bladder cancer, there are potentially ways that we can actually integrate them into treatment of high risk. So I think the future hopefully will all be about preventing these cancers from occurring, and I hope also as well in huge smoking cessation campaigns that we can make a dent in preventing bladder cancer in the first place for more people.
Well, that actually, I think, maybe ties into a question we had, which is, what is the main cause of bladder cancer? And we don't really know, but we know that smoking is a main risk factor. Correct?
Yeah, I mean, there are the traditional exposures such as smoking, and there are solvents and dyes that you can be exposed to. There are many well-described risk factors, and sometimes it's bad luck, and sometimes some people do inherit some I have no other way to say it, inherited DNA repair deficiency. Sorry. So sometimes people don't repair their DNA very well, and it leads to cancers like bladder cancer or upper tract urothelial cancer. So, it's complicated. Hopefully, there are preventable reasons, and smoking is on the top of that list. So, less smoking, less bladder cancer.
All right, thank you, Dr. Ong. Thank you. I think we have 2 minutes left here, so we're going to wrap it up. Just an excellent Q&A. We had lots of time, which was fantastic, and lots of really great questions from our audience. So I really I appreciate the everyone's attention and the thought you've put into the questions for this evening. Again, I'd like to extend our sincere appreciation to you, Dr. Ong, for joining us this evening. Just an incredible job delivering a session that was easy to understand and absorb. And the visuals, they really help me along too, to help understand a lot in a lot simpler way bladder cancer. So, it's because of caring and generous professionals like yourself that we can offer sessions like this at no cost to our community. I'd like to also thank the rest of you for being here with us, and we hope you gained some really valuable and new information this evening that can be applied to your own situation. And please be reminded that you will receive a recording of this webinar, as well as a feedback survey within the next week or so. So we ask that you take a few moments to complete that survey so we can continually improve the services we offer here at BCC. I'm just going to put up my my last slide here. And but should you find you need information or support of a more general nature or of an emotional nature at any time throughout your treatment or your recovery, your journey, please keep in mind we do have that one-to-one peer support program with trained volunteers. You can just call us, you can email us. We also encourage you to join our online discussion forums, subscribe to our newsletter, on our website, and check out our social networks. I've listed them here, Facebook, Twitter, Instagram. You'll find all those links on our website. And lastly, we invite you to volunteer with us if and when you're ready. There are many ways which you can help to fulfill our mission to support patients, increase awareness of bladder cancer, and fund research. And with that, I'm wishing you all a wonderful evening, and please stay in touch and enjoy the rest of your night.
Good night.